So rare diseases really don't get the research attention that we feel they deserve. So they're about, you say the word rare diseases and um, people just think, well, that doesn't affect very many people. And, why should we care about rare diseases? But while it's true that most rare diseases have very few patients affected, with 7 to 10,000 different rare diseases, are actually about 25 to 30 million rare disease patients in the United States, which is about 1 in 10 in the population. So that's a lot of people. Um, and we also know that rare diseases for the most part are single gene disorders. So they affect very fundamental biologic processes. So our patients tend to be very sick. They have serious illnesses, they have high unmet medical needs, and only about 5% of our diseases have an approved therapy. So they're just really large unmet medical needs. And but the rare disease patient community would not be surprised to hear this at all, but there's just a lot of anecdotal evidence that rare disease is very expensive. So high cost, which we're also referring to as like cost burden or is a surrogate for high utilization, and high utilization is a surrogate for being very ill. So we were hypothesizing that the costs would be up there with other serious diseases, but it hadn't really been, when we started at this, it hadn't really been quantified in any kind of a systematic way. So these so-called cost of illness studies have been done for other diseases like Alzheimer's, for example. They did that a few years ago and showed, very high costs. And what that led to was a lot of attention about, we really do need more research into this serious disease. And we're like, well, we really need to do the same thing. We know our patients are ill. We know they have unmet needs. And what we really need is solid, objective information around that. So that's why we set out to do this study. We were trying to quantify what we thought we already knew, but we needed the data. So what we did is we got together with several partners outside of NIH, because with 7 to 10,000 different rare diseases, you can't just look at a few of them and say, well, this represents every rare disease. So we just deliberately went out to try to include diverse representation into our study out of the gate. So we spoke with one of our colleagues in Australia, and then a couple of academic medical centers, starting at Oregon Science and Health University. I think I always get that backwards. And the PI later moved to Colorado, and Sanford Health, the colleague there, and then a data analytics company called Eversana. So we got together to try to figure out what was the most useful way to do this. So we decided to do a retrospective study of querying either health systems database at one of those institutions, or by using like insurance databases to try to take information that was already there, try to do it in a standardized way, and to see if we couldn't start putting some numbers around this. So this is a very difficult thing to do with rare diseases, because again, we have lots and lots of different diseases, but also because so many of them are small, they don't have their own individual ICD codes, which is a very typical way that you look at studies like this. You try to find, some codes that you can do consistently across your disease or disease area. So that's pretty hard to do for rare diseases. So what we did, instead of trying to look at all 7,000 or so diseases, we deliberately went through and tried to pick some representative diseases, and we ended up with 14, and they differed by age of onset, populations involved, organ systems, whether they affected young children, older people across the lifespan. Some were episodic, some were chronic progressive. We just tried to get as much diversity as we could. And some had ICD codes and some didn't. And then through discussions with our partners, we tried to come up with a consistent way of looking at this to see if we could put some, consistent numbers across the healthcare systems. So that was kind of step number one. Is it possible to develop a technique to quantify this that could then later be scaled up for many more diseases? Then what we wanted to do is have a better idea of where the costs were going, where it was being spent. So we were only looking at direct medical costs. We could not look at indirect costs, things like, days lost at work or school or out-of-pocket expenses for patients. And then finally, we wanted to see if this sort of algorithmic or data analytic approach could be used to clue us into being able to identify rare disease patients quicker. Getting a diagnosis of rare disease is very hard. It happens so often. It's called the diagnostic odyssey. There are some estimates it takes 5 to 8 years on average to get an accurate diagnosis. We were trying to see if by looking at this and by looking at patients' clinical journey as we were looking at these data, if there were some clues within these journeys that we could use to develop some kind of machine learning techniques that would help identify patients sooner. So it wouldn't necessarily be that we would have to home in on the exact disease, but was the pattern of utilization, were there things about that might help escalate people and get them referred and diagnosed faster. So that was kind of why we did this and how we went about it. So the results, which are, again, no surprise to the rare disease community at all, but the costs of the direct medical costs of having a rare disease are very high. So against a non-rare disease control, they're at least 3 to 5 times higher on average than someone who doesn't have a rare disease. It also appears that, and we're also trying to get, prevalence, see if we can get some kind of consistent prevalence estimate looking at the different insurance databases or healthcare system databases. So, we ran into all kinds of difficulties doing this, again, not at all unexpected right out of the gate, but we had a couple of diseases that didn't have ICD codes. So we tried to see if there were some straightforward things we could do to find the disease otherwise. A lot of these diseases are included under what we call umbrella codes. So neuromuscular delay, developmental delay, seizure disorder, which, these can encompass a large number of diseases. So 2 of our diseases did not have a specific enough code that we could accurately identify them. So one of them, pheochromocytoma, which is a rare tumor, what we were able to do is tie the ICD, more general ICD code, to more specific lab testing and get a fairly accurate number. Another disease, Charcot-Marie-Tooth, which is characterized by very slowly progressive peripheral neuropathy, we were not able to do that easily. So that's going to need some more research. And then in terms of prevalence, the numbers were they were all over the place. And now this could have been that, since a lot of diseases are genetic, they can cluster in certain populations or in certain databases. And it could just be that the populations where we looked were different. Or it could just be that, again, with difficulties with diagnosis and especially accurate diagnosis, that we're just not able to home in on these accurately enough. So we need to do more work there. And we are doing more work there, but that was, part 2. Then we tried to put some costs around this, like how much was the health system being paid for these. So that we did with the database that NCATS was using, which is mostly a state Medicaid database out of Florida. Florida is a very diverse state, but this is a public health database. And our other partner, Eversana, who was looking at a very large insurance claims database that included commercial and public and other insurance. So what we found, and this again is not surprising, that the public health database, the costs were lower, but in every case, they were much higher for rare diseases than they were for a non-rare control. And it was just really cost of illness, cost of serious illness, cost of being sick, ICU admissions, frequent ER admissions, frequent hospital stays, and expensive procedures and support. So again, that's not surprising, but we do have now hard data around that. And then the final thing we looked at is we took two diseases, cystic fibrosis and Batten disease. Cystic fibrosis is a lung disease. Batten disease is a progressive neurologic disorder that affects young children. And we took the two highest cost patients in each of those diseases and just took a look at their journey, trying again to see were there clues in here that might clue us off to this could be a rare disease patient. So again, what we saw was just really frequent hospitalizations, catastrophic illness, serious consequences of disease. And interesting how this worked out is we had one CF patient who had early intervention with disease modifying therapy and one who didn't. So the one who had the disease modifying therapy, the costs were similar, but it shifted to an outpatient. It was mostly cost of, the drugs and the what you would think of as a typical consequences of the illness, much, much less so. And it was basically, it appeared that this was somebody who was on, chronic drug therapy, but it sure looked like was otherwise doing pretty well, as opposed to the other patient who was diagnosed late and had irreversible complications, serious complications of the disease. And we saw the same pattern for Batten disease. One had a disease modifying therapy, one didn't. Costs were about the same, but how they were being paid were different. Went predominantly to outpatient chronic maintenance therapy versus progressive, irreversible, terrible complications and the expenses associated with that. So that was an exploratory study, but for all of these things, we want to know more. And coincident with our doing this study, some other groups actually did similar, but not the same study. So you may have seen the Every Life Foundation did a survey on burden of rare diseases where they quantified the direct costs as well as the indirect costs, and they ended up with similarly very high utilization and cost numbers. A health system called Aurora Health also looked at things a different way and compared people with a rare disease diagnosis versus not for inpatient hospital costs. And interestingly, rare diseases accounted for about 50% of costs. I think it was on the pediatric side, also extremely high in the hundreds of billions of dollars in a year. And then the GAO just recently came out with a report. So here we now have 4 reports in a relatively short period of time, all showing the same thing. So I think this is really putting facts and figures around what we always knew.